so we have covered a lot of abdominal grounds because, again, like I said, there's a lot of organs in there to think about. But the other things to think about now are the chest and sort of the anatomy there. And much of this is more detailed than you need to know, but just so you have a sense of what we're actually looking at, here we're looking at the highest sort of level, right? We're looking up almost at the level of the very apex of the lungs. And here you have the three brachiocephalic, common carotid, and subclavian arteries coming off of the aortic arch, right? Here again, see this, the trachea coming down, and that'll be black, right? Because it's air-filled, lungs on either side. And then we have the esophagus as well. As we come a little lower down, now we're below the level of the arch. Ascending aorta comes up from here, arch is over, descending aorta here, right? So to the front, not as much because we're in the thorax, right, in the heart's here, but to the left of the vertebral body. And then we're now below the bifurcation of the trachea and below the carina. And now we're at the five vessel view of the heart. So you can see right ventricle, right atrium, left ventricle, left atrium, and the aortic root immediately before the ascending arch. And so again, same thing here. And these are just coronal slices of the exact same thing. So now we're looking just at different, anterior, posterior, and middle of the coronal images. So again, lungs on either side. And this is really the money shot here. If you can see the four vessels, you can see the aorta, IVC, and this is the general anatomy we're working with. But again, predominantly what you're going to be given is these axial views. And then just briefly on lung windows. So same thing as what I said about bone windows applies here. Basically now you can see, I don't even know where the bones are, right? Because it's so difficult to discern the bones apart. But this helps me see the lung parenchyma very, very well. So this, whenever you see a certain window, the thing that you can see well is probably the thing that you're supposed to be looking at for exam testing purposes. So don't even worry about the bones here. They're not trying to show you anything. They're trying to show you what's going on in the lungs. And these lungs look pretty normal, but that's just an example of the windowing that you can see to better see the lung parenchyma.
All right. Let's take us to a case. So this person, first thing we want to do when you look at the lungs, we want to see if anything jumps out at us. And, what I'm seeing jumping out at us is this structure's kind of here, kind of in this almost reaching out kind of pattern. You could almost see that these almost look like train tracks as they go out to the periphery. This person would probably have, a productive cough. We got a lot of the right.
Everybody's got it.
Got this one. All right. As Sana said, maybe we got to make it harder for you guys. Yeah. Too easy.
Perfect. Yeah. So exactly like I said, we see these very, very prominent bronchi. And like Blake mentioned earlier, you should see tapering, right? In normal anatomy, you see this main stem bronchus, it gets smaller and smaller and smaller and smaller. Here, this does not look like it gets smaller at all. And this, you should not be able to see such clear, large vessels or bronchi so far out.
Okay.
Okay.
Take us through another one, Sana.
Another one. This one's a little harder. Let's see how you guys do with this. So again, looking at the lungs, axial slice. Oh my God, some people are already getting it. Okay, never mind. I'm gonna have to be harder still. We're seeing very, very random distribution of nodules, right? So we see tiny nodules all over the place, and they are everywhere. They are disseminated. They are miliary, one might say. And so this sort of diffuse pattern of lung nodules is very, very characteristic for miliary tuberculosis, right? Everywhere.
Very good. So since this is too easy for you guys, so let's say this patient now presents with hypotension. So what do we think happened there?
Yeah, they give you this chest CT and give you a TB history, whatever, and then they tell you they're hypotensive. They're in shock. What's going on? Why are they hypotensive?
Yeah, exactly. We got him, Sana, a little bit.
Oh, we finally got him.
All right.
All right. Oh, all right. We got one person who's got it so far. Oh wait, yeah.
Yeah. All right. One person's got it. Good job. We can't tell who though, or else you guys will know. All right.
Nice. Okay, perfect. So
Good.
basically, big thing about miliary TB is miliary TB, yes, certainly goes to the lungs, but it can be everywhere, right? And so the one thing that is a very common site for miliary TB is the adrenal glands, right? And the adrenal glands are very important in production of glucocorticoids, which are also involved in the entire RAS pathway system, right? Renin-angiotensin-aldosterone system. And so because of that, the miliary TB causes destruction of the adrenal glands, and you can see this hypotensive pattern because of the lack of glucocorticoid synthesis. So again, couple of levels there, but that's how they're going to test you on the USMLE exam.
Yeah, thank you, Sana. Very similar to Waterhouse-Friderichsen syndrome and how it affects the adrenal glands there. All right, let's take us to another one. I'm glad we were able to trip you guys up at least a little.
All right, another one. So, okay, this is a good one. So, same history. Let me tell, I'm going to give you this image and I'm going to tell you it's the exact same history. So, a patient who's coming in, no history of vaccination, recent immigrants, they're coming in with shortness of breath, maybe a productive cough, and they have this CT finding. What am I looking at here? Anybody have any ideas? So the big things when I'm looking at this image, I do see a lot of nodules, right? So there certainly could be a miliary TB component here. But what's jumping out at me is this really black lesion here inside the lung, right? Why am I having this level of blackness in the lung parenchyma? And you see this sort of surrounding hyperdensity. And so this here is a cavitation. So this is a cavitary lesion, which can be caused by tuberculosis. So this is more a sequela of chronic manifestation of the disease, right? Versus miliary TB is like just the acute stage. This is a manifestation of chronic disease. So again, TB history totally fits with this. They could also have a history of something else. Cavitary lesions can be caused by prior pneumonia too, but certainly can be seen in TB as well.
Absolutely. And another way you could reaffirm that to yourself is looking and seeing, okay, wait a second, where am I? Okay, I'm in the superior lung fields, and that's going to be helpful as well. All right. So patient presents. This one's a little bit trickier, I think. So what are we thinking? I don't want to give away too much for you guys since you've been getting everything so quickly.
Nailing it. Yeah. Oh my gosh. Why do we even try?
I know. All right. Okay, so what makes this one different than the last one? The last one that was filled with a structure that was completely black. This one's filled with a structure that's white. So kind of big difference there will help us exactly at fungus ball. Thank you. In the colloquial terms, that is what it's called. And so this is aspergilloma. So perfect. So absolutely.
Yeah, the one point I'll add to this is that the reason you can tell this is an aspergilloma and a fungus ball is you can see that it is contained within the cystic lesion, right? This is not in the lung tissue. This is contained within that sort of blackness of the cystic cavity. And so this is a fungus ball that forms inside that cystic cavity. So different than if you saw it in the lung parenchyma and I saw this white mass-like lesion, I'd be like, oh man, I'm worried about, a malignancy. But it's because it's within this cystic lesion that you know that it's much more likely to be a fungus ball. All right, we got another one. So this one I'll give you. Patient is a 38-year-old man who is coming in after a motor vehicle accident. And then they get a PAN scan because they were in an MVC. So what am I looking at here? So here okay, you guys, I'm just gonna breeze right through it. This is pulmonary contusion. So as we see here, we have this density, this irregular, almost soft tissue-y looking density in the lung. And then on the lung window, you can see it's very focal, it's anterior. If you looked at this patient's history, I'm sure they would have a history of wearing, often a seatbelt is the classic thing that you think about, right? Because the mechanism of injury, you're jerked forward and the seatbelt's restraining you back. And if there's enough force, then it can cause significant injury to the lung because of that blunt force trauma. And so this is especially that history plus that geographic distribution, right? If you see it in this one anterior distribution, pulmonary contusion for sure.
Absolutely. I think the thing also that helps you here is this vignette, as always. I know we keep on kind of looping back to the same things, but that's because this is what gets these questions right. The same patterns, consistency. This patient's gonna be kind of fine, you know. Like you're gonna look at your assessment, you're gonna be like, what's wrong with them? They're kind of okay.
Yeah.
And then you're going to be like, then you're going to come down and you're going to say, okay, this one essentially says they're kind of okay. So you trust your assessment there and you don't jump to some kind of big diagnosis because they're on 1 liter of oxygen or they're on room air and they're satting fine. And this patient isn't the patient that's going to present with all the other scary stuff. This patient's going to be fine. And then you're going to have to trust yourself in that. And that's one of the hardest things on the exam is just trusting yourself to work with students.
Definitely. Nice.
Thanks. Okay.
Oh, boy.
Someone presents with...
let's not even give a history. Let's just see. Let's just see what happens. People can just get it.
All right. They already got it.
They already did.
All right. So if we want to orient ourselves here, so we can find our vertebra here, and then we can find just anterior and left of that, or right on our image, is our descending aorta. In front of that, in front of this kind of bifurcating vessel, we have our ascending aorta, and then we have this kind of bifurcation here. And this bifurcation is our pulmonary vessels. And as you guys so astutely found, this kind of area here is a saddle embolus here. So one thing that I really like to mention here, to contrast the thing that we went over at the very beginning, our first case, which was that person with congestion. If you guys remember, the pulmonary congestion, that's going to be usually caused by the heart, and that backup is in the pulmonary veins. Just like in the body, veins are leakier. And so usually when we get lower extremity edema, that's going to be from veins as well. So that pulmonary edema that we get in the lungs is from backup kind of from the heart into the veins. This picture, pulmonary artery, sometimes you can get some pulmonary edema, but less likely to get crackles on exam here. Usually the lungs will be more clear with a pulmonary embolus, as opposed to this kind of pulmonary edema picture, more commonly caused by the heart, will give you those crackles. And that's kind of a big difference, I think, that you kind of figure out as you move along.
Yeah, nice. Okay. And as a companion case to one of our cases from before, we're looking now at a coronal image, right? And so again, I'm looking at lung windows, and this is a slightly challenging image, but what I'll say is, looking at the lung fields, right? Because again, they're giving us the lung windows for a reason. I see almost in the distribution of the branching bronchus, right? So this is the right main stem bronchus, and you see a branch coming up here, branch here, branch here. We see this sort of like ground glass opacification surrounding the bronchus. And similar here, right? Similar here. A lot of septal thickening and a lot of vessel engorgement, right? So this is, again, also in a very central pattern, right? You see it starts from this central pattern, starts from near the hilum and branches outwards. So think about how when I may have used those same terms before, central pattern, branching outwards, and you're seeing this sort of white opacification in this branching pattern. What does that remind you of? Perfect. A bunch of people are getting it already. Good. So this is always going to be, again, central, branching, pulmonary edema, the end. And so this patient probably, again, they'd have some sort of heart failure history, something to further support that. But this is why you get that X-ray image, right? Remember that X-ray where the periphery looked kind of okay, but the center was all hazy and white? that is because of this is the underlying CT for that same sort of pathology. Awesome.
Thank you.
So pulmonary edema.
The perfect segue there. All right. So now we're back in the chest. We're looking, and so again, not a lung window here. So I'm not looking at the lungs, even though we're in the chest. They're not showing me that. They're showing me a soft tissue window here. So why are they showing me a soft tissue window? Okay, so when I'm looking here, I want to look for things I know. So I'm looking right here at the vertebral bodies. I'm looking at the lung fields. Do they look equal? Well, first thing, well, they don't look quite as equal as they normally do. There looks like there's some stuff back here. And additionally, it looks like, yeah, that looks like kind of, it's fluid dependent. We kind of get those meniscal lines, like you get in a test tube, making me think that there's some fluid back there. Because if it was air would create more of a straight line. And so that kind of fluid, that meniscus, makes me think that there's fluid there. So
nice.
Yeah, so this one's a hemothorax. So a lot of different things can cause this. Anything to add here, Sana?
Yeah, the only thing that the reason that we say hemothorax specifically, and this is a little bit advanced, is that if you really squint and really like try with me here, if you can see this one area here is a little bit denser, right? This sort of bottommost portion is a bit lighter, and this sort of superior area is a little bit darker, and that represents clotted blood. And so that makes you think of hemothorax. And again, subtle, advanced, don't worry about it if you didn't see it, but that's why I know it's a hemothorax.
Great, thank you. Learning something new.